This is Leonor Fernandez. Wonderful to join you and to this terrific team. I think we've all heard at this point and read many publications that really support the idea that patients love being able to access the notes. And we know the positive feelings include, feeling more in control of healthcare, of your healthcare, feeling more confident about being able to adhere to medications, and then feeling more able to find errors in your care. Now, we also wanted to understand what patients might find not so positive from reading notes. And we wanted to understand that in part because clinicians were raising this issue that Jared nicely outlined in terms of being worried about offending patients. So what we did was ask. So next slide. What we did was through an internet-based survey of 3 health centers, the one here at Beth Israel Deaconess in Boston, it's an academic health center. We asked at University of Washington in Seattle, including a safety net hospital, and in Geisinger Rural Integrated Health System. We asked survey respondents how they felt. Basically, we asked, specifically, did you ever feel offended by something you read in a note? And separate question, did you ever feel judged by something you read in a note? So we had almost 30,000 survey respondents, and here's what we found. So about 1 in 10 are telling us that yes, they either felt offended, judged, or both. 10.9%. Specifically, you see here 7.9% felt offended, 7.4% felt judged, and more than half of them overlapped. Clearly, this is important, and we want to understand this, who's feeling offended or judged. So next slide. Some preliminary data, which we presented at SGIM, along with my colleagues. And what we found, one of the most predictive issues in the demographic was self-rated health. So if people felt that their health was fair or poor, they had pretty dramatically increased prevalence of reporting that they felt offended or judged by something. So as you can see there, there's over 20% of people who reported poor health who felt judged or offended. And then, and this group overlaps, people who say they are unable to work, employment status, felt more judged and offended, also over 20%. So next slide. We wanted to understand what was offending them and making them feel judged. So we did a qualitative analysis, and we're submitting this now for publication. So the overarching domains of what we found. So at the top in orange, you see errors and breaches. So the single biggest thing, above 20%, that made them feel that way is when we got it wrong, when we put something that was a mistake or inaccuracy in their view in the record. Breaches refers to when they felt that we somehow breached their trust, something that didn't meet the expectations of what they expected in a note from our behavior. More on that in a moment. Right, the labels is when we characterize them in some way, usually of their person, of their identity in some way, or close to their identity, in a way they felt was inappropriate or unfair. And on the left, disrespect referred to the fact that they found the tone or some of the content at times disrespectful. And then there were some assorted other themes. Now, if we go to the next slide, we'll see at a more granular level, because I'm sure many of you are interested in what specifically errors and breaches. So starting there, I mentioned that mistakes and inaccuracies, and these were the specific mistakes and inaccuracies that they thought were offensive. So it's not usually left or right knee for this thing. What offended them were things that were more close to somehow to their identity and to the relationship with their clinician. Did not happen in a visit, meaning that a physical exam, for example, was documented, which didn't happen, often because we're importing, a copy and paste kind of boilerplate note while we're writing it. Rarely they alluded to feeling that the clinician lied intentionally. Often often they talked about a diagnosis not being discussed. Sometimes this may be because we're importing a problem list. And so they wondered, why is my mental health problem being listed when I go to the podiatrist, for instance, and then confidentiality concerns refer to the fact that sometimes they shared something in what they presumed was a confidential private sharing with their clinician. It was never explicitly discussed, but they thought it was confidential, and then they see it in the note and they wonder why that level of detail is in there. So finally, for disrespect, they felt some of the tone we use is cold, but beyond that, they thought it was condescending at times. They felt that we weren't always reporting well what they said. So we're either misquoting them or didn't apparently hear something that they felt was important and should be in there. And then clinical language and conventions is interesting. Some of our language that Jared was just referring to is inherently kind of weird, I gotta say, just plain old fashioned and weird. And so when we say things like patient claims, as though it was a legal, claim, or refuses or denies or endorses, or even quite honestly complains of, which is the bread and butter of what we say, it's kind of a strange construction when you think about it. And then there were other sort of things we say routinely, like well nourished, that they misunderstood to think that we're sort of trying to slyly say they're overweight when that's just the regular way we typically say that. There, this is, thank you, a word cloud, which I find often in one quick picture kind of conveys what you're trying to get across in terms of what patients tended to bring up in these free text responses. Most of these responses were like 3 words to a full paragraph. And these, we took the adjectives that came up more than 20 times. And you can see obese, incorrect, wrong, personal, sexual, upset, offensive, etc. Anxious. I'm realizing that I may have skipped the personal descriptors. Did I? I didn't say in the labels, I apologize, that obesity was one of the big ones. Gender and sexuality pronouns, often in our transcription, that gets messed up. Also, when we get it wrong, but sometimes it's just our transcription. And then things like elderly. My favorite comment was a woman who wrote about a young doctor saying she was elderly. She was 60. She wrote insolent pup, which I thought was amusing. So, and other stigmatizing topics. So if we can skip to the next slide again, sorry. So take home points. The patients want what Jared said. They want the note to reflect the visit. They don't want a surprise. And they also want the visit to reflect the note, which is interesting. They want us to make sure we're talking to them about any new diagnosis, particularly any new diagnosis we're making. They want their perspective documented. And this is particularly important when we disagree, when we don't have the same point of view about something. They want to be respected by their perspective being somehow faithfully recorded there. And again, to summarize, the top concerns for patients were mistakes, not feeling heard, feeling labeled, this skeptical, judgmental idioms, and this issue of obesity and mental health diagnosis being mentioned, which in situations they found not as relevant. And again, all of this is not to mean we should change everything we're doing, but these are important things to guide us as to which situations we should think about, their vocabulary, our idioms should evolve, and how we should talk about things in a note and in the office. So thank you.